Welcome, everybody. It's so great to see so many GBV specialists on the line representing so many countries from our region and then also around the world. My name is Jessica Gorham, and I'm the Regional Emergency GBV Advisor based at UNFPA, but working on behalf of their mandate to coordinate GBV and emergencies through the GBV area of responsibility. But for the purpose of today, I am also the co-chair of the Regional GBV Working Group for East and Southern Africa. We are co-chaired by the GBV AoR and CARE International. And this is part of an ongoing series that we have called our Emerging Practice series. And so we try to highlight best practice and promote good work that's being done at field level. You might have attended a previous emerging practice webinar. We had one actually last week. It was pushed from our January one, which was about mainstreaming risk mitigation measures throughout nutrition programming. And we've had them throughout the past few years. So please do keep looking for our invitations to our emerging practice webinar series. If you would like to see or listen to other emerging practice webinars, you can find them on our YouTube channel, which is the GBV AoR.net YouTube channel. And you can just put that in your search engine and find them there. I'll talk a little bit for those who are new to this forum. We do have some ground rules. We would be most grateful if you could make sure that your videos are turned off. And this is so that we can make sure that those who are calling in from areas that might not have the strongest internet connection can stay streaming. And we will also please request that you put yourselves on mute throughout the presentations. If you have questions about any of the presentations, you may write them in the chat. Myself and other colleagues will be monitoring the chat throughout the presentations, and then we will ask those questions at the end to the various presenters. So please, if you have any questions about any of the information that is being presented today, please do write those questions in the chat. We will monitor the chat, note your questions, and then we will present them to the speakers at the end. And the reason we do it this way is because normally, as you see, we have many people joining us today, and this enables us to group like questions together, and then also to see who is best to respond in terms of our speakers. So please do keep that in mind. As I said, it's very great to see all of you on the line. Please feel free to write your name and organization and where you're calling from in the chat. This lets us know how our outreach is doing in terms of getting our invitations out to different countries and through different forums. So thank you for that. Please also note that the presentations, all of the presentations will be sent to you. We have your email addresses. Since you did register with us, you will receive all of the presentations and a link to this recording. But also please remember, if you'd like to go back over the recording, you can also find it on our YouTube channel at gbvaor.net on YouTube as well. So without further ado, I think we'll get started because we do have a full schedule today. I'm really happy to introduce our colleagues who will be talking about the differences and the complementarity between women and girls safe spaces and also one-stop centers. And the reason that we thought this was timely is because that we noted in our region, particularly the East and Southern African region, that we are seeing lots of rollout of one-stop centers, particularly in emergencies. And we want to make sure that we're doing fit for purpose. And we're not rolling out one-stop centers at the exclusion of all these wraparound services that we find very necessary in order to make sure that we're strengthening social networks and referrals as well. So please keep that in mind as we progress throughout the presentations. And as I mentioned, if you have any questions, please do write them in the chat. We will be monitoring the chat and then presenting your questions at the end. I'm very pleased to present our speakers for today. Our first speaker will be Joanne Crichton, who is the program director for the GBV AoR's Helpdesk. And as you note from our beginning slide here, she will be presenting the paper that the Helpdesk produced. And it looked at understanding the core functions and differences between women and girls safe spaces and one-stop centers. Next, we will have Ami Kande, who is the GBV and emergency specialist for UNICEF based in Tigray, Ethiopia. But she will be sharing some of her experiences rolling out rainbow centers, which are considered best practice among one-stop centers in Sierra Leone. And finally, we will have colleagues from South Sudan, Florence Adio, who is the GBV AoR co-coordinator in South Sudan, but she is based at IRC, the International Rescue Committee, and she will be joined by her colleague, Glory McKenna, who is the Women Protection and Empowerment Coordinator, also based in South Sudan at IRC. So we're really pleased to have so many experts on the line to give a little bit of background and then also experiences with one-stop centers and women and girls safe spaces. I will now turn it over to Joanne, and welcome.
Thank you so much for that introduction, Jessica, and hello everybody. And thank you very much for the invitation to join you for this webinar today. As Jessica mentioned, I'm Joanne Crichton, the Program Director for the GBV AoR Helpdesk. And the Helpdesk is a free and confidential research and advisory service focused on gender-based violence in emergencies. I'll be giving you an overview of a new GBV AoR Helpdesk resource, which has been developed to assist gender-based violence practitioners, MHPSS and health specialists, as well as policymakers operating in humanitarian settings, to understand the differences between women and girls safe spaces, which I will be referring to as WGSS, and one-stop centers, which you'll hear me mention as OSCs, although one-stop centers often have a range of different names, but I'll be referring to them as OSCs. So drawing from key tools and guidance, the paper outlines the key characteristics of each type of service, their benefits, and some of the potential limitations that each has that need to be addressed as part of the design and implementation phases of a project. And this resource can be used as a reference tool when you're considering how to ensure comprehensive care for survivors in a given setting. And we hope that this paper will be useful for advocacy purposes to ensure that the scale up of one type of service, as Jessica mentioned, most often one-stop centers, does not take precedence over or eclipse the other service, in this instance, women and girls safe spaces. The priority is to ensure that women and girls have access to safety and protection and a choice of where and when to seek support when they experience gender-based violence. And so a one-stop center should never be used as a replacement for a women and girls safe space. So let's dig in now and begin by understanding the origins of WGSS and OSCs. Well, women and girls safe spaces emerged to provide survivors with a way to access services and support, primarily psychosocial support and GBV case management, in a non-stigmatizing way. They're frequently used in humanitarian settings, yet they can also be used in development settings too. In addition to PSS and GBV case management, WGSS provide other resources and support fundamental to women and girls empowerment, including skill sessions, livelihoods, and social and recreational activities. In some instances, women and girls safe spaces have leadership committees, and management invite others to provide services on site, for example, visiting lawyers or paralegals, midwives, nurses, and other clinicians. Whereas one-stop centres evolved out of the sexual assault referral teams or sexual assault referral centre models from the US and UK. And these were designed to respond to rape and other forms of sexual assault and ensure health, psychosocial support, police and legal services were available in one place to facilitate access for survivors and seek to ensure a survivor-centred approach across service providers. In some locations, OSC's origins were driven by a focus on increasing prosecution rates for sexual violence offences, and therefore they place significance upon evidence gathering and collection. OSCs began to operate in Thailand in a tertiary hospital, providing acute services to survivors of violence. OSCs were then established in Malaysia, with the model then replicated throughout the region. And OSCs, as we are now discussing, are now also implemented more broadly across several different continents, including Africa and also Latin America. Next slide, please. So what is a women and girls safe space or a one-stop centre, and what is their purpose? On the screen, you will see a definition of both types of services. The Women and Girls Safe Spaces one, it comes from a global toolkit, which was developed by two leading INGOs with decades of experience of operating women and girls safe spaces. And they define them as a structured place where women and adolescent girls' physical and emotional safety is respected, and where women and adolescent girls are supported through processes of empowerment to seek, share and obtain information, access services, express themselves, enhance psychosocial well-being, and more fully realize their rights. Whereas there isn't a globally standardized definition of what a one-stop centre is, and they can vary in structure and the services provided, but they usually focus on providing a direct response to a survivor who has experienced an incident of violence. And as I said before, that's usually rape or sexual assault, though not exclusively. And when one-stop centres there are usually 4 different types of OSCs that have been identified through research. These can be hospital-based tertiary care one-stop centres, quite a common model. They could be health-based one-stop centres run by NGOs. And increasingly, they can be operated by NGOs with co-ownership from local governments or national governments. There can also be standalone one-stop centres, and in this model, the one-stop centre is in a separate location and is typically NGO managed. And these usually provide a range of multi-sectoral services. And finally, there can be one-stop centres located within other sector services, for example, based out of a local police office or at a courthouse. Next slide, please. So what are the delivery objectives of women and girls safe spaces and one-stop centres, and who are they for exactly? So let's have a look at that. Next slide, please. So again, there is definitive guidance that outlines the objectives of women and girls safe spaces. And these objectives are 5-fold. They intend to facilitate access for all women and adolescent girls to knowledge, skills, and a range of relevant services. They support them to have psychological well-being and create social networks for them. They serve as a place where women and adolescent girls can organise and access information and resources to reduce the risk of violence. They serve as a key entry point for specialised services for GBV survivors. And they provide a place where women and adolescent girls are safe and encouraged to use their voice and to collectively raise attention to their rights and needs. Whereas for one-stop centres, there is no singular stated or standardised objective documented at a global level. However, some of these objectives have been stated in country and local level documents. And it's an objective, a broad objective of facilitating reporting and medical examinations for survivors to coordinate investigation and support services and prevent survivor re-traumatization when seeking care as a common theme that tends to focus in terms of a delivery objective for a one-stop center. Next slide, please. So who are one-stop centers for? One-stop centers are for all women and girls, including GBV survivors. And the core focus of a one-stop center is to assist women and girls who are survivors of rape and other forms of sexual assault, though they may also provide support for survivors of intimate partner violence and other forms of physical violence. One-stop centers are focused, therefore, on providing medico-legal care of sexual assault through health or justice facilities, and they can also provide services for male survivors of sexual violence. Next slide, please. Let's now have a look at the principles which underpin each type of service. Again, for women and girls safe spaces, these have been specified, and again, they're fivefold. You can see them on the screen, so I won't run through them all, but it just will highlight specifically the aspect of solidarity and inclusion, those two. So in terms of solidarity, this is grounded in feminist theory and practice. Women and girls safe spaces provide a space for diverse networks of women and adolescent girls to come together, providing them the opportunity to support and inspire each other through sharing, mentoring, and cooperation. And in terms of inclusion, women and girls safe spaces are committed to celebrating diversity and improving how women and adolescent girls access, participate, and shape women and girls safe space services. Equally diverse women and girls safe spaces staff and volunteers should demonstrate impartial and inclusive attitudes, beliefs, and practices. Whereas for one-stop centers, again, there is no overarching global level guidance document that sets out the operating principles, but some of these have been documented and codified within country or facility specific guidance documents, sometimes known as SOPs, standard operating procedures. And when they're written down, they tend to follow common themes where they mention being driven by survivor-centered approaches to care. They want to ensure access to healthcare and to facilitate prosecution. Next slide, please. So what are the core activities and services delivered by a women and girls safe space and a one-stop center? Next slide, please. On the screen, you can see a summary of the core activities and services. So please follow our full list. But just to highlight, you'll see on the left-hand side of the screen, we begin with GBV case management for women and girls safe spaces and psychosocial support. Those are generally definite core services provided. Plus, there's a whole range of additional activities which I've touched on before, but I won't go into details because I'm sure some of our other speakers will, Florence and Glory, later. For one-stop centres, the focus on core activities tends to be healthcare, specifically clinical care for sexual assault survivors or clinical management of rape and treatment of injuries, sometimes also in terms of support for women and girls that have undergone FGM. They may also provide GBV case management. There may be a police focal point or legal and justice representatives present. Now, these are just the core services. In addition to these, there's a whole raft of additional activities and services that may happen within a women and girls safe spaces. I won't run through them all. They're documented in the paper, which you'll have the link to. But just to highlight, they generally can include income generating activities, have child-friendly spaces where there's supervised childcare, and a whole range of other activities besides, including linkages to GBV risk reduction activities and to outreach and GBV prevention work. For one-stop centres, additional activities might include psychosocial support, and again, they might have a child-friendly area, especially for child survivors who may need to access clinical or PSS services. Next slide, please. Now, in brief, there are, as I'm sure you're starting to pick up, also some areas of overlap and complementarity between these service types. Both respond to GBV survivors, both should have female staff and volunteers, and for women and girls safe spaces, this will be exclusively the case, female-only staff. They should both provide safe, ethical, accessible, confidential, and non-discriminatory services. Both can provide clinical care for rape and sexual assault survivors. Both may provide menstrual hygiene management supplies, and both have the potential to have significant positive impacts on individual survivors and wider influence on institutions through their advocacy efforts. Next slide, please. So what results do these types of services have the potential to deliver? On the left-hand side, you can see a range of results or outcomes that may be achieved from a women and girls safe space, depending on their service offer. And similarly for one-stop centres. And you'll see the slight variation in different numbers and types of outcome we might expect to achieve through each different type of service. And so again, this really highlights it's very important that we have that both services have an offer to make in terms of supporting survivors of GBV. Next slide, please. And are there any specific considerations or requirements? Well, the answer in brief is yes. Of course, we've talked about the need for both to provide safe, ethical, accessible, free and confidential and non-discriminatory services. In addition, there's quite a lot that needs to be considered in terms of placement of services, how services are signposted, the signage, how the spaces are designed, and of course, making sure that there is adherence to the GBV guiding principles. And usually within a women and girls safe space, that they tend to factor for disaggregating activities by age, so that, for example, adolescent girls or older women can have some sessions which are distinct for them. And this is to make sure that there is safe participation and that there is safe intergenerational learning, socializing and exchange between women and girls in a women and girls safe space. In terms of the one-stop centre, it's really important, as I mentioned, to think about layout and to also make sure that if it is an integrated service or a standalone one-stop centre, that no one area becomes very obvious as to be a treatment room, which for survivors, because then that could jeopardize safety and confidentiality potentially. And of course, for both services, it's very important that there is training, adequate training, quality training, and of course, adequate supplies and materials. There's a lot more detail in the paper. I don't have time to touch on all, I'm afraid now, but please do check out the paper if you'd like more details, and we can discuss further in the Q&A. Next slide, please. So what are some of the limitations or challenges? For women and girls safe spaces, unfortunately, they are rarely sufficiently funded to allow them to deliver the full range of activities, which limits the potential for impact and transformation and full achievement of those results that we mentioned. They also need to be carefully oriented and positioned within their surroundings to make sure that they can achieve their transformational impacts and be accessible. Also, unfortunately, due to lack of funding, it can be challenging for women and girls safe spaces to have the funds to fully adapt their premises to be accessible to women and girls with disabilities, for example, who may have unique mobility and communication barriers to accessing their safe spaces. And generally, again, down to resources, they're generally not resourced to provide services 24 hours a day, 7 days a week. But they may be able to provide a crisis or emergency line and support safe referral out of hours. For one-stop centres, there can be several limitations. Again, sometimes they require more space and more resources than they're provided with. And if they're administered or linked to the justice system, they may overly focus on prosecution and perhaps not sufficiently on women's mental health and well-being and psychosocial well-being. A medicalised approach that also does not address all forms of violence or more than one incidence of violence may place insufficient emphasis on counselling, peer support, or creating space for solidarity and support among women and girls, and gender transformational approaches. And finally, on this point, the presence of men and boys in health settings may deter some women and girls from accessing services. This can be for a range of reasons, including but not limited to lack of safety, additional re-traumatization, fear or risk of honor-based violence if they are in the presence of men who are not related to them. Next slide, please. So thank you very much for listening to me today to give you an overview of the paper. There's a lot more detail in that paper that I haven't discussed, but please, I encourage you to check it out. And details of the types of services that the help desk provide are on the screen for you now, as well as how you can contact us if you require some technical research and advisory support. Thank you very much.
Thank you, Joanne. We've had questions coming in fast and furious, so we will, as I noted, I'm trying to monitor the chat. There are some that I'm answering in real time, and others I'm giving you a link to resources that you can look over to find the answers, and others I will note for the speakers. So please keep that in mind as well. And I will, thanks again, Joanne. I'm going to turn it over to Ami Kande, who is our UNICEF colleague working in Tigray, but she will be sharing an example of best practice about this complementarity from her time in Sierra Leone. Over to you, Ami.
Good afternoon, all. Jessica, you've already introduced me, but my name is Ami Kande. I'm the UNICEF GBV IE specialist in Tigray, Ethiopia. Good afternoon, all. Good morning, good evening, depending on where you are. Next slide, please. So basically, my role here is to actually talk to colleagues about my time establishing a one-stop center, commonly known as the Rainbow Centers, and operationalizing those. Today, those centers are now, they've become a non-governmental organizations and they've continued to actually function. But I just wanted to give you guys my own practical experiences and how that has moved on. As we all are aware, the 11 years war in Sierra Leone was marked by brutal human rights abuses, of which sexual violence against women and girls was committed. But what had happened is that when the peace accord came in, on the ground, there was not that capacity to be able to respond to the conflict-related sexual violence incidents that had occurred. Immediately after the war, IRC was able to secure money from DFID, and through that, they were able to establish a whole GBV program, of which their response, direct service delivery response, was through the Rainbow Centers. So between the years of 2003 and 2004, which I actually oversaw the establishment and functioning, is what I'll walk you through. Then I can come back to the subsequent years. And these Rainbow Centers were embedded within district premises, but managed by IRC. The focus of the centers basically were to provide age-appropriate, survivor-centered psychosocial and medical services to survivors of sexual violence. So these services basically did not, although they were located in the district towns, but they actually were providing services to the surrounding communities as well. Their core services: medical examination and treatment for all injuries that was caused by the assault. So basically comprehensive clinical management, that was something that was done, and referral for surgical interventions, and counseling to help cope with the emotional and psychological effect of the assault. But basically in our counseling sessions, it wasn't only focused on the individual that has been affected, but we actually supported the families as well, because other than the individual, families were affected. So we had one-on-one, everybody that came through the center, actually with whoever they came with, they were actually part of the counseling session. It wasn't together, it was individually done based on the needs that was assessed. And if this was somebody that basically happens to be the perpetrator, we basically moved that person and handed them over to the police. And as part of the support, all the survivors that came through, all the staff that were at the Rainbow Center were trained on as paralegals. So basically, we did not have police or lawyers based within the centers, but the staff that are the counselors, their background are actually psychologists or social workers. They were trained as psychologists, and they were able to provide that paralegal information and allow the survivors to make a choice. And if the survivor chose to, that they want legal action, the center was able to help them to facilitate that process in reporting the case to the police. The reason being that we really did not want the police within the centers. We wanted to build an institutional structure. And again, prosecution of rape in particular is a criminal offense. So that rests on the state. So we wanted to build those structures to be able to not just provide support to clients coming to the Rainbow Centers, but to those that choose not to get any of the services, but preferred legal action. So those that wanted to do that, so we built that institutional structure for them to take ownership, because we felt that if we move the police services into the security services within the Rainbow, it will be seen as a standalone. So we did not. So they were within the police stations. And again, the atrocities that were committed in Sierra Leone, the sexual violence, most of them were by the uniform personnel. So all of these people who worked within the police stations were actually wearing plain clothes. And in terms of people going in, we had social workers that were employed by the government deployed within the police station. So investigations and was done in collaboration with the social worker being present to provide support and to avoid re-victimization to the clients. And referrals was something that was actually done for services that were not provided. The services were accessed through various channels, self-referrals, but our main referrals were done through the women's action groups, whom I will actually come back later and talk about. And again, the police and other institutions. Can we get the next slide, please?
You have 4 minutes, Ami.
Oh, geez. Okay. You already have the figures. Most of our clients actually came through, if you look at it, they were mainly children. And we spent a lot of time working with communities. You have this on the side, given time, I'm going to have to run through it. But again, our service model was basically informed consent. All survivors coming through, we actually inform consent, allowing the survivors to determine the service and direct the support required All the staff at the center were women, and we only had midwives and counselors. And the profile of the counselors were either social workers or psychologists providing context response services. What we did is putting power in the hands of the survivors to decide the next course of action. We did that. What we did as informed consent is not to include psychiatric services as part of the initial crisis package. Why? Because we did not want the survivors' experience and healing process to be associated with mental health support. Although some of them needed that, they were referred as part of that process. The police, as I've already highlighted, they were based in the police station, and support was provided. All cases that came through the Rainbow Centers were issued medical certificates, even when they didn't want to take the case to court. Those medical certificates were kept on file, and if survivor wanted medical action later, they were able to come in and they return, and then they did not have to go through the whole process. Their certificate was there, aiding their support. Community Women's Action Group, they actually were referring 90% of the cases that came through to the Rainbow Centers. The reason is that we wanted these women, we build their capacities to be able to provide support to the survivor in the journey to access services, their recovery, their families, and the social network. And again, because we at the centers were only able to provide services, then at the end of the day, we went home. But they were that local community that needed support. And there was a lot of family crisis because if a child is being raped, and especially when we had a lot of children that were born out of wedlock, this is where the Women's Action Group came in to provide a safeguard, not just to the women, but to the children, and to stop further abuse. Accomplishment, survivors basically were accompanied to services. I'll jump the other one. Then again, additional services, outreach and community engagement was another big component of our programming. In communities where sexuality is seen as polluted, where rape is being condemned as the woman's fault, we paid a lot of emphasis on community understanding and acceptance of survivors, knowing that it wasn't their fault, they had not. So the next, they had not the ones that are actually allowed for the incident to happen to them. Capacity building, because a lot of the people, again, we need to realize, women and girls who come to the center, they are community members, they come from families. So how do we build capacity to ensure that there is that continued support? So there was a lot of emphasis on Women's Action Group, health facilities. So when people came in for initial services, on their way back, we refer them to the local healthcare center. So at least there was that localized service available. Then really, as part of our process, next, advocacy was another one. Legal advocacy and health. Today, I can say that part of that has resulted in gender acts that have become law, part of our legal reform. Can we go to the next slide, please? When you look at quality control, so a few of the things we instituted, bi-yearly, there were two actually meetings bringing all actors together so that we could actually talk about what the issues are, then jointly plan to be able to move whatever the bottlenecks are. Bi-monthly meetings looking at case reviews that the staff were actually doing, provided that on-site training for all of them and reviewed. But again, a critical part of our programming was survivors' feedback. That was so important to us because we were serving the survivor, we needed to hear from them. So service feedback mechanisms were included. So next slide, please. Then today, really, to look back, the Rainbow Centers are no longer IRC. Before I left IRC in 2011, we had actually developed a strategy to have the Rainbow Centers become an NGO based on the community call. Today, they are an NGO running on their own. Then again, getting partial support from the government. Then they serve actually 45,000 survivors. Their focus is no longer on sexual violence, but it's on GBV as a whole. Then the other thing again is that I would like to highlight is that the Rainbow Centers through their own expansion and through their advocacy. In 2017, Gender Acts were enacted, then the Sexual Offences Act of 2022, 2012 was enacted. And again, there is a lot I could say, which I'm more than happy to say in because of timing. But again, these learnings from other areas, Sierra Leone, mainly West Africa, that's what I brought to Ethiopia. And working with our colleagues, we've started actually transferring those knowledge to the program as UNICEF within Ethiopia. Thank you.
Thank you, Ami, and thanks for your presentation. As I mentioned, we have lots of questions coming in. I am sifting through the questions, looking for like ones. If we can answer them in the chat, we will. My colleague, Christine Appio, who is also part of the GBV AoR team here at regional level, she will also be, you might see her name, she is going to also be answering questions in real time. So if you do see her name answering questions, she's part of the GBV AoR team and the regional GBV working group. I will turn it very quickly over to Florence and Glory. And if you could please keep it to maximum 10 minutes. Thank you very much.
Great. Thank you, Jessica. Hi, everyone. Good afternoon to you all. I'm Florence Adio, the GBV AoR co-coordinator, together with my colleague here.
Hi, everyone. My name is Glory from IRC.
Yes, thank you so much. So we'll look at the best practices on women and girls safe spaces in South Sudan. Next slide, please. Yes, so I'll give a bigger perspective of this, and then Glory will come in with the practical examples from IRC. So in terms of the 2022 data that we have, we had a total of 23 GBV partners managing women and girls safe spaces programming in South Sudan. And then in terms of the GBV partners, the women and girls friendly spaces are between 2 to 21 being managed by a partner. And this is in the different locations in South Sudan. Also from the 5 Ws that we have extracted, we have seen that we have reached a total of 103,827 women and girls through activities at the women and girls safe spaces. IRC alone reached a total of 42,396 women and girls, which gives us a total of 41% of the total that GBV AoR reached in 2022 for the women and girls safe space programming. And these ones are located in Awil East, Juba, Koch, Mayendit, Panija, Pariang, and Rupkona. And these are in 3 states out of the 10 states in South Sudan. In 2023, the GBV AoR is targeting a total of 217,782 women and girls to be reached. And we hope that we will get in there, putting in place, advocating for more funding and the rest so that our partners are able to reach, a bigger number of women and girls. Thank you for this. I'll hand you over to Glory McKenna.
Thank you, Florence. We move on to the next slide. So the experiences and practices we are sharing today are mainly informed by the reflections that we've done with women and girls across the communities that we serve. So one of them is it's essential while working with women and girls at the safe spaces to build trust. That is mutual trust with the women and girls, and that will promote their participation as well as the ownership of these safe spaces. And this we've been doing through setting clear and mutual expectations at the very onset of our engagement, especially on clarifying what is possible and what not possible. And also in addition to that, promoting transparency by working with WGSS committees or the women networks, so that they contribute to the ownership as well as the running of the women and girls safe spaces. In addition to that, we strive to ensure that we continuously engage women and girls through continuous feedback to get inputs on how we can improve our engagement with them and probably incorporate the suggestions for our future projects. In addition to that, the location of the women and girls safe spaces is very critical, because if it's not in a safe and accessible place, then it will create barriers for women to access, women and girls to access. So we've ensured that our women and girls safe spaces are in locations that are safely and accessible, and also closer to other service providers, for example, the health facilities, the one-stop centers, to enhance the coordination and also the referrals for survivors or women and girls in need of other services. In regards to the ongoing interventions with the women and girls at the safe spaces, we've seen the continuous engagement has increased the understanding about violence against women as well as GBV, and also the role the women and girls should play or can play in the community in breaking social norms that normalize violence against them. Additionally, also we've seen an increase in terms of women supporting each other, in terms of accessing safe services, GBV services, whenever they or someone they know experiences GBV. And also, in addition to that, as part of strengthening the capacity of women and girls, we've seen the listening sessions that we have at the safe spaces have provided opportunities for women to share and inspire one another, and therefore providing them with opportunities to establish social support networks, which continuously increases their solidarity and support for one another. On empowerment, as many of you know, the IRC WP program is mainly rooted under the empowerment principles. So we've ensured that the women and girls safe spaces are avenues for their empowerment. They are more of empowerment spaces where we provide information, support them to access services, as well as provide life skills which are critical for them to thrive in the communities. And through the empowerment, we've seen the confidence of women and girls increasing, and they're able to speak on their behalf in the community on issues affecting them, and also challenging the communities, especially the community leaders, on key things that are putting their protection environment at risk. And that has really been very good advocacy, especially at the local levels. And also we've seen through the skill building, some of the women have picked it up from just being a social empowerment, translating them to economic empowerment, where they're able to identify groups, establish the Village Savings and Loans Association, and that has enabled them to be economically dependent and supporting in generating incomes for their family. In regards to women passion and for their activities and sense of ownership, again, working with engaging the women and girls to promote their passion in ownership has been very essential, especially where women committees are formed to support in the co-learning of the women and girls safe spaces, and placing the women as at the center of our response, at the center of our interventions, so that even when we as IRC are not there, we believe that the capacity of the women is sufficient enough to ensure the continuity of this women and girls safe spaces. And then the referral systems are very instrumental, and mapping out the existing services in the locations where we have the women and girls safe spaces has been critical, ensuring that these referral pathways are functional and women and girls have safe access and as well as coordinated access to the GBV services. Among them, the one-stop centers, the health facilities, and this has increased in terms of the timeliness of reporting of the incidents, as well as in terms of the help seeking behaviors among women and girls. And in addition to that, also continuous engagement with women and girls to inform them on where and how to seek services has also been helpful because they're able to support one another. They're able to ensure that survivors have the full support to access the services. Then also the leadership and advocacy is very key when engaging with women and girls. And this is through capacity building initiatives, trainings tailored to address leadership, local advocacy, and recognizing the existing capacities within the women and girls that you can tap on to propel their advocacy, as well as provide opportunities for them to speak and advocate for a protective environment in their communities. Then the women networks, as well as the women committees, have been instrumental in ensuring that the safe spaces are placed at the key center of the women and girls. They support, they play a key role in terms of managing the centers, ensuring that the activities are incorporated as per the suggestions and the recommendations of the women, and also play a key role in terms of ensuring women and girls in the community are aware of where the women and girls safe spaces are located, and also in terms of information sharing on GBV. During the key calendar events, these are the teams, these are the women who plan, these are the women who organize for the events, such as International Women's Day. They sit down together with the women, develop advocacy messages, they design how they want their day to be, and that has really contributed to the ownership of these days, and also in terms of them getting empowered and feeling that this is indeed their space as women and girls. And then in regards to inclusion and the localization, working with community-based staff and ensuring that we incorporate the diverse groups that we have in the communities, including women and girls who are abled differently, has really been essential, because women are able to identify with the team that are based in the women and girls safe spaces, and also ensuring that the staff working at the women and girls safe spaces have impartial and inclusive attitudes, beliefs, and practices that recognizes the key principles of the women and girls safe spaces. And then in regards to inclusion also, identifying the women and girls at the communities who are abled differently, and supporting them to integrate with the other women at the safe spaces, and where possible, linking them with other service providers for support. For example, through the ADCAP humanitarian inclusion, we've been able to refer women who have mobility or hearing and they have received support that has enabled them to access the women's centers and also participate in the activities that are availed at the centers. And lastly, it's critical to have mechanisms that monitor the activities. And for us, we've been utilizing the regular women and girls safe spaces feedback surveys, which we conduct with the women and girls at the safe spaces. And together we are able to sit and reflect on what we need to improve on, what has worked well for not just us as IRC, but also for the women. And that way it contributes to the trust building that I mentioned earlier on. Next.
You have 1 minute, please.
Yes. So Florence will take us through the recommendations.
Okay, all right, thank you. In terms of the recommendations, we are looking at the funding. For South Sudan, we have seen partners, having funding for 6 months, and they have taken 3 to 4 months, going through land approval, construction of the women's and safe space. So they start implementing around the 4th month, and by the 6th month, the funding is ending. So that does not impact anything on women. And so we are advocating for funding for a period of at least 1 year to ensure that, this is impactful to the lives of women and girls. And we have seen that also most of the women, they prefer to be in the women and safe spaces because it feels more safe for them to be there than in their homes. As you know, the context of South Sudan, it's basically comprised of conflicts, a lot of conflicts and flooding. So women find the women and girls friendly spaces more safe for them and more of a home than their own home. We are also seeing that there is need to invest in inclusion so that no woman or girl is left out. Glory already mentioned the inclusion aspect. IRC is already working with humanity and inclusion to ensure that challenges that affect women in terms of distance to the women and girls safe space can be resolved by giving them wheelchairs or some aid to ensure that they're able to access some of these facilities. In terms of sustainability strategies, we are looking at how best we can work with the Ministry of Gender, Child and Social Welfare to ensure that there is continuity, but also within the community, what can they do? What can the women do to ensure that these facilities continue to support women and girls, but also still linked to the funding issue because the context is so much depending on the humanitarian aid. So these are the sustainability issues that we are looking at. Then lastly, linking women and girls safe spaces with other sectors for integrated services. For example, linking them with the issues of hygiene and wash and sanitation, linking them with food security, livelihood, sexual and reproductive health, including, family spacing, cash and voucher assistance, because this is where, they get a lot of information and they're able to be linked to ensure that they get, holistic kind of intervention to improve their lives as women and girls. Thank you.
Great, thank you. Thank you both to Florence and Glory for that really comprehensive presentation. If I can ask you to please give me a kindness of an additional 10 minutes. As you know, here at the Regional GBV Working Group, we like to maintain time, but we had so many questions that I think I want to be able to throw some out to our presenters. So I'm asking as a kindness to stay with us for an additional 10 minutes so that we can answer some of the key questions. One of the big ones that came out across the chat, I think by many people, there still seems to be a little bit of confusion about the differences between a one-stop center and a women and girls safe space. So we had many participants who asked, but I still don't know when to implement a women and girls space compared to a one-stop center. And I want to throw this over to Joanne. If you could first maybe address that, because as we have stated, these are two distinct services, but they should be complementary to each other. And then the second question, Joanne, we had a question about setting up one-stop centers in emergency settings and whether that promotes best practice as well. Over to you, Joanne.
Thanks so much, Jessica, and thank you for the questions. I would, in terms of kind of purpose and objectives, delivery objectives, in brief, what I would suggest is that for women and girls safe spaces, if it helps to think of it this way, they are dedicated centers or a space, doesn't need to be a physical center that's constructed, but a safe space that is exclusively for women and girls to come together with the purpose of, coming together for different types of activities. which can also include, and always tends to always include, because it's a core activity of a women and girls safe space, they act as an entry point for GBV case management and psychosocial support that is delivered usually within that safe space. So that, if that helps, but in addition to that kind of core service, so much more is provided, as you heard from Florence and Glory talking through all the different types of activities that tend to be provided within women and girls safe spaces, so that women and girls can access a range of different benefits. In terms of one-stop centers, they were originally conceived, and they tend to continue to be conceived as places where women and girls or male survivors of sexual violence can go to access clinical care when they have experienced a specific incident of sexual violence. So in other words, this means that, for example, they may not, a survivor perhaps of intimate partner violence, which is a pattern of abuse, more than one incident, may not necessarily identify that a one-stop center is a space that would meet their needs, because the focus of a one-stop center is to deliver that clinical care within an immediate term, to provide that, to avoid the harmful consequences of sexual assault. They also tend to be, in some settings, linked to, as we've discussed, a justice response or to police. So to have an investigation and evidence gathering that may potentially lead to prosecutions. So hopefully that helps to clarify a bit more the distinctions. One-stop centers most commonly are within health care settings or centers, sometimes hospitals, sometimes clinics. Or, as I mentioned, they might be embedded within a different type of service, such as a police station or a courthouse, though that tends to be less common. In terms of the aspect around whether to implement a one-stop center in an emergency, I would say that when the GBV AoR Helpdesk conducted a review of the available, and I should stress the available, learning on this issue, what we found was one-stop centers have tended to be implemented in post-conflict, as Ami was explaining, post-conflict settings in Sierra Leone, or in more stable settings. And so the learning that we have in relation to their advantages or their limitations generally comes from post-conflict or more stable settings. So it's hard to say. But one example would be in Eastern DRC, the Panzi Hospital that was implemented where in locations where there was high incidence of conflict-related sexual violence. However, that is somewhat of an outlier of a service because it was incredibly well resourced and sustained, and continues to be sustained over the long term. So that's, you know, many services, as we know, do not receive that type of and level of support to be able to offer comprehensive services in a sustained manner in conflict affected or emergency settings. And I see that our colleague Christina Pio gave a great response to this question as well, specific for South Sudan. So thank you, Christine.
Great, thank you, Joanne. So it sounds like in terms of a women and girls safe space, we also offer a broader range of sort of social services that you might not always find at a one-stop center, which is more clinically and specific response-based, is what I think that I'm hearing there. But also I do recommend, please do go onto our website, gbvaor.net. IMC and the IRC did develop a Women and Girls Safe Space Toolkit, which you can find on our website on behalf of the GBV AoR. And many of the questions you had posted in the chat can be found in that resource as well. Joanne mentioned that we did have a previous emerging practice webinar that focused specifically on one-stop centers. And we had that webinar last year as part of our Emerging Practice series. You can find the recording to that webinar on our YouTube channel, the GBV AoR YouTube channel. If you have more specific questions about one-stop centers, please do listen to that recording because it might answer some of those as well. I'm going to pose 2 more questions because I still have 7 minutes. The next question I'm going to ask is to both me and Florence and Glory. We had a lot of questions around monitoring and evaluation. And you did a little bit, Florence and Glory, touch upon it, but I'm also asking Ami, what were the systems or protocols in place in terms of monitoring and evaluation that ensured that your services or those that you were working with meet standards of care, which is of course what we promote here at the GBV AoR and UNFPA. Over to you.
Thanks, Jessica. In terms of really the program itself, one of the things that we had in place that in terms of data collection, that's something we had an instituted data collection database initially, which later we had the GBV IMS that actually informed our programming. That was something that was was instituted. Then the other one really in terms of monitoring the quality, we had actually the internal data collection. Then again, the other thing which we had was the women's action groups, which is really the community groups. They had a fundamental role in monitoring those activities. So again, because survivors returned, families returned, they had an engagement with them. So they are able to give us that feedback. Then the programming, then the survivors themselves is another one. Then actually we had supervision from headquarters, IRC headquarters in New York, around the region that actually came in to provide that monitoring as part of it. Then evaluation, we had every 2 years, there was a program evaluation and the feedback fed into the programming.
Great. Thank you, Ami. Florence or Glory, just very quickly, can you just speak specifically about monitoring and evaluation, a very key component of all services provided for survivors of gender-based violence? Over to you.
All right, thank you, Jessica. Thank you for the question. In terms of monitoring the activities at the Women and Girls Safe Spaces, we have the monitoring tool already in the Women and Girls Safe Spaces tool, where we extract and then we contextualize to our context, in this case, South Sudan. So first of all, we do by training the staff that work within the Women and Girls Safe Space to ensure that, you know, there are ethical considerations in doing that. And then secondly, in terms of the client feedback, it is done by those staff that are trained, but not a staff that works in the women and girls friendly space, because that can bring in some bias. So we would want another staff who is not working in the women and girls friendly spaces, but, you know, with the consent to do the client feedback so that they rule out the bias, and then they get the satisfaction surveys done with the women and girls friendly space. In terms of monitoring the activities within the women and girls friendly spaces, this is done through the same staff who have been trained. There are different programs, afternoon programs, morning programs, because like for South Sudan, the demand is very, very high. So in terms of timing and activities to take place, like we really need to ensure that we manage this in terms of making schedules, afternoon schedules, morning schedules for the women and for the girls. So it's done by the staff that are trained. And at the end of the project, you know, this is the M&E component is done, and then the feedback is given back to the women, depending on what the clients have given us in terms of their concerns, in terms of the areas that they would want to be improved on, in terms of what progress is being, done by the women, and maybe in terms of any other arrangements that they would want to be included in their programming. So this is done at the end of the project. Thank you.
Great. Thank you, Florence, and thank you, Glory. I think we will wrap up because we are a bit over time. I know that there were a lot of questions in the chat today. I really strongly recommend that you reach out to your country level GBV AoR coordination mechanism or coordinators, whom are usually based at UNFPA. As we mentioned, UNFPA is the lead for coordination in gender-based violence and emergencies. For instance, if you're in South Sudan, it would be Florence at IRC, it is co-chaired by Fanta. Please reach out to them. If you're in Somalia, it would be Nikiru, also based at UNFPA, and then in Ethiopia, Karanja. So please do reach out to your coordinators who are based at country level if you have continued questions around these two models. But also, as mentioned, you can find more resources both on women and girls safe spaces and one-stop centers at the GBV AoR website, which is gbvaor.net. As mentioned, we did have a previous emerging practice specifically on one-stop centers, which can be found on our YouTube channel. So please do keep that in mind. I'd like to thank everybody for joining us today. It was really great to see so many practitioners on the line asking so many thoughtful questions. This is how we are going to move this phenomenon forward, is by having all of you invested in making sure that services are reaching a global standard of care. And so we really appreciate you. I saw so many of our women and led organizations from South Sudan and Zambia and all around the region. We particularly appreciate your presence at these forums because you bring in the context that we need so that we can also better understand these issues at regional and global level. So thank you so much for joining us. On behalf of my co-chair, CARE International, of the regional GBV working group, we so much appreciate your attendance. Thanks to all of our speakers today, Joanne, Ami, Florence, and Glory, and particularly to our colleague Shiva, who's based at global level, who is providing tech support, and also to our regional team here at the GBV AoR. Thank you so much for your participation today. It was so much appreciated. And please do join us for our next emerging practice webinar, which we hope to have in March. Thanks, everybody, and it was great to see you all online.
Thank you.